welcome to Mad Medicine with Miss P. Today we're going to talk about care plans. We did NANDAs, left off with NANDAs last week, and I'm sure there's more we can get into and some more questions, but since I didn't get any, we're just going to keep on moving on because I'm sure you're all like just waiting to get to the meds and you're just like, let's hurry up, and I understand. So we're going to get to the meds, but right now, as far as care plans go, it's important that you understand how to do this. It's not that tricky, I assure you. I know I keep saying that, but y'all want to make it harder than it really is. So as soon as you come up with your NANDA, you start thinking about your care plan. My care plans begin as soon as I walk up to see my patient. As soon as I recognize their age, their sex, their height, their weight, whatever it is, I start to kind of create a plan of care. And what I mean by that is, for me, what I do right now is outpatient surgery. So when I go to grab this chart and I see that this person is having a knee surgery, if it's a 10-year-old boy, I say, hey, cowboy, what'd you do? How'd you hurt your knee? What happened? And then we kind of, bring the parents back and we, do their thing. When I see it's an 86-year-old man, I say, hi, my name is Gina. I'm going to take care of you today. And then I, address his family and let them know what's going on. And then we slowly walk back. I slow my talk. I slow my walk. I make eye contact. I look for hearing aids to see if I have to increase my tone of voice. Your care plan begins as soon as you meet your patient. So after taking care of a patient for a while and you come up with your NANDA, your plan of care shouldn't be too difficult. So let's say we talked about last week a gas exchange thing, right? Okay, so if I had a problem where my patient had an issue with gas exchange, meaning their O2 sat was, let's say, below 94, under 95, that sort of thing, with or without oxygen. Let's pretend they have 2 liters. So if you have a COPD patient that takes oxygen, supplemental oxygen via nasal cannula at 2 liters per minute, you're going to begin your assessments finding out what your biggest issues are and how you're going to fix them. Your plan of care is how we're going to improve that O2 sat, which means your goal after you have your NANDA, so impaired gas exchange related to loss of elasticity of alveoli walls as evidenced by O2 sat at 94% with O2 at 2 liters per minute by nasal cannula. So you're like, I'm already giving them oxygen and still this is where their sat is. So you have to come up with 5 things. For us, it's 5 things you want to do to improve their O2 sat, right? Because the evidence is what you want to get rid of to prove your plan of care is working. So first you have to set a goal. So your goal has to be realistic. Don't pretend you're going to be curing emphysema. That's not what's happening. So your goal has to be like, patient will maintain an O2 sat of 96 or greater with O2 at 2 liters per minute by nasal cannula continuously per MD order, right? So you're not going to take their oxygen away. You're not going to cure them to where they're not going to be on oxygen anymore. Or maybe it is possible that they get 295 and stay there with weaning them off oxygen. We'll see. But let's kind of just say short-term goal. That's what we'd like to see. So what types of things can you do to improve their gas exchange? First thing obvious, you're going to sit them up, right? Most patients with COPD, they can't even lie flat. They have all kinds of issues lying flat, orthopneas, what they call it. They have to kind of sit up straight or in a recliner to breathe easy, right? So you're going to sit them up as often as tolerated to encourage inflation of their lungs and decrease that kind of gravity push onto their chest while they're lying in bed or in a recliner or anything like that. So encourage patient. It should always start with an action verb. Each intervention should start with an action verb. So encourage patient to stay in high Fowlers as often as tolerated throughout the day. So, and then you're going to explain, right, your rationale. I don't even read the rationales unless I can't figure out where you come up with this intervention. The intervention is so ridiculous, I don't know where you came up with it. Then I'll read your rationale. And then sometimes I'll say like, oh, I see where you're going with that, but not quite. Or, all right, okay, makes sense. Maybe we just have to reword your intervention a little bit to make it make more sense. So in this case, we're going to encourage them to sit up as often as tolerated to improve that pulmonary expansion and help them breathe deeply without, kind of being hunched over or crushed in a chair. And you've seen, you walked into a room and you see them, they're all slouched down and they're kind of chin to chest and stuff. So get them in a position to where they can breathe and inflate their lungs, easily. And then your eval of that is going to be what was their oxygen saturation after having them sit up, let's say for 20 or 30 minutes. It's not patient, sat in high Fowlers for 20 minutes. Well, good for you. Okay, great. Did it help? Remember that evaluation is evaluating your goal, not just met my goal, met my goal, met the goal, met the goal. It's what was the result? What did you find? What did you see? What did you hear? What did the patient say? Your subjective and objective data that you can prove what you're doing is making a difference. So if you have them sit up for 20 minutes or 30 minutes, nonstop, and it didn't make a difference, well, then obviously that may not be a great concern, or it maybe need to be coupled with a couple of other interventions. So you kind of continue down the line. So the next thing we might want to do is, if it's a patient that keeps taking their oxygen off, you might encourage patient to wear O2 at 2 liters per minute by nasal cannula per MD order continuously if they're removing it. If they're pretty straight with it, you don't have to add that as an additional intervention, well, then leave it out. So then you might want to do things to improve their gas exchange, like have them turn, cough, and deep breathe. While that doesn't necessarily change the gas exchange at the alveoli level, if they can cough up things and kind of help their airway to an extent, then you're going to help things get to the bottom to exchange. So you can kind of work that a little bit. And again, have your rationale, and then did it help? Also, pursed lip breathing, that's huge. Remember how important that is to breathe deeply in through the nose, real slow and real deep, because the deeper you breathe in through your nose, which takes a lot longer, and if they can hold it for just a split second, it gives more time for those gases to exchange at the alveoli level. Now, while you have your O2 sat on, you're going to see a change if they correctly pursed lip breathe. I will forever see a change in their pursed lip breathing when they do it correctly. Even with my own family, I've seen a huge difference. Even over the phone, I've said, put the O2 sat on. Now listen to me, breathe real deeply in through your nose. Take your time, hold it for a split second, and then let it out real slowly, kind of like you're flickering a candle, not blowing out the candle, but flickering the candle. And the longer you leave that oxygen in there, the longer it has time to exchange. Now, while those things will help gas exchange, some other things like for airway, if we give them a nebulizer treatment, which will decrease inflammation, which will allow better oxygen saturation, and exchange, you can do that one and also see the difference. The reason I don't say stuff like monitor or assess or observe, you already did all of those things that led you to decide they have impaired gas exchange. So I know there's probably plenty of other instructors out there that will say, like, monitor O2 sat, every 2 hours. Well, we already did that. That's how we decided that their O2 sat is too low. It's not to say you're not going to continue to do that. That's how you're going to find out. It's kind of a given. So I always say do things that are going to make a change instead of doing things you would normally do, like monitor their color, or assess for signs of cyanosis. You're too late. If you do any of that, you're too late. The whole point is to not let them get cyanotic. So anything below 95, that's not our goal. And you shouldn't be cyanotic at 94. So what things can you do to improve their gas exchange? So if you think about those types of things that can improve their ability to exchange gas, inhalers, administer Solu-Cortef, 125 milligrams IV push, Q6 hours per MD order. It's kind of more of an airway thing, but it will assist obviously with gas exchange. So you don't want to branch into a different NANDA if you can help it, but sometimes they do overlap to an extent. So I always say, like, the example I use, and I try to use this in class, or I did, because if I gave you all of these examples, like with this particular care plan, you would just write it down even if it didn't apply. So I kind of give an example, like if I wanted to lose, if my goal, let's just say that it was imbalanced nutrition greater than body requirements related to a significant caloric intake with fairly sedentary lifestyle-ish, as evidenced by extra meat around the midsection that I don't want, right? So let's just say my goal was to lose 5 pounds before June 20th. Okay, let's just say that was the goal. So while this can sort of be a care plan to an extent, if you're going to do, obesity or the imbalanced nutrition, if you think of 5 things that are going to get you to your goal, it is not observing, monitoring, looking, checking, seeing, assessing, and checking the scale. Those things will not make you lose weight at all. So the example I use is because there's multiple things, a lot of interventions we can think of to help lose weight, but it's not about the desire to lose weight. It's not about self-motivation. Those are really good care plans, but those are different care plans. And right now we're just talking about losing weight. So what do I have to do to lose 5 pounds before June 20th? I have to stop eating after 6 p.m. I have to fit 20 minutes of cardio in every day. I have to limit or, set a goal that you could, or an intervention that you can kind of measure so because you can't really say limit it to what. I have to cut out, let's be realistic, cut out my afternoon snack, which is generally like a vat of ice cream the size of my head. So cut out my afternoon snack, drink 8 glasses of water a day, like make sure I drink all full 8 glasses of water a day, and switch my zone bar in the mornings to this tiny little pathetic kind bar that is like the size of one strip of a Kit Kat, which I have done. So let's say those 5 things should help me lose the weight if I do all 5 of them, not necessarily just one, but if I do all 5. So in this case, the same difference is your evaluation of each intervention would have to be to get on the scale, to get on the scale, to get on the scale, to get on the scale. You have to see if you're losing weight. It's not to see, do I fit in that little black dress? Do I look thinner in the mirror? Do I feel thinner, or do my clothes fit better? Those things are not going to be measurable in the sense of proving you are meeting your goal and those interventions are working. So if you kind of think about it like that, if you think about how can I prove that what I'm doing is making a difference, because you're not going to keep doing something that doesn't work. If you have a patient that is having trouble breathing and you give them a certain medication and you don't see a result of it, well, then you're not going to keep doing that, right? That's the definition of insanity, doing the same thing over and over, expecting a different result. So you have to evaluate the response of that particular intervention. It's not one evaluation that says, I met my goal, everything is fine, or her SAT stayed at 96%. You have to evaluate each individual intervention. And that's what tells you, is it working? And if not, you have to do something else. That's why we have care plan meetings. So we decide, is this working or is it not? So let's say we have somebody of imbalanced nutrition, less than body requirements. They are skin and bones and you cannot get them to eat, or the staff has tried. And now you're thinking like, okay, I'm here, I'm going to make something happen. What 5 things can you do to get this patient to gain weight? So first of all, set a goal that's realistic. You want them to gain 5 pounds by June 30th, right? And you can maybe even do it a little bit sooner depending on their appetite, assuming they're able to chew and swallow safely, right? So the first thing I'm going to do is find out what she likes. What are her favorite things to eat? And I'm going to supply her with those things, right? Then I'm going to keep snacks and favorable supplements within reach. That's another thing, that I don't have to be in the room. I can make sure she has them. I can make sure that if she has a sip of something and she doesn't like it, I'm going to take it away and replace it with something better. So by looking at that thing that was grossed her out, or she didn't like the taste of it or the smell of it, I want to improve her appetite by getting it out of there, and I'll put something else in place, right? I'm going to encourage her. And you go in there and say, wow, you almost drank all of that orange juice. Good job. And people like to be told, or given gold stars. Don't pretend like you don't like the gold stars, the coveted gold stars. People like to be rewarded. So encourage and reward, and give her stickers, give her anything that, bribe her. I'm not afraid of bribing somebody. I will take you to bingo, early, and you can get a good seat if you, just drink this Ensure for me. And as soon as you finish it, I'll take you. And if you don't finish it, then, I'm not going to take you until you get that in you. It's not about being their friend, and it's not about torturing them. We're not going to make them eat something they don't like or anything like that. But it's getting that job done no matter what. My patients may see me coming and think, oh God, not her again. But I'll tell you what, they're going to be better when I'm done with them. I may drive them crazy. If someone is dehydrated and won't drink enough, I'll come over and kind of sit them up and sort of dig my fingers into them a little bit and kind of make them uncomfortable. Even if it means do what I say, then I'll go away and I'll leave you alone. I'm not there to be your friend. I'm there to make you better. So whatever you have to do to make this patient better, use rewards, bribe them, encourage them, verbally, emotionally encourage them as much as you can. Get them things that they want to eat, anything that that they enjoy. Bring them snacks in between mealtime. Make sure when you're filling out their menu that you're getting things that they actually really like. If they say like, Yeah, I guess the oatmeal's fine. Say, hey, you don't have to have that. We can get you something else. Let me go to the kitchen and see if I can't ask them if they got other options, if there's nothing on this menu you like. Do whatever you have to do to get the job done. Meet your goal one way or another. So I know there's a bunch of different care plans we can talk about, like impaired skin integrity related to poor perfusion to bony prominence is evidenced by 3 centimeter beefy red wound bed with pink surrounding tissue to mid sacrum, right? So the goal is patient's wound will decrease to 2 centimeters by 1 week period, let's say, whatever that date may be at the time. And then how are you going to make this wound better? First off, number one, how did it get there? Reverse that sign. The patient will have zero pressure over this area at any given time. I don't care if you wedge them to the left cheek, wedge them to the right cheek, sit them up, lean them, back, lean them forward, whatever you have to do. No pressure on that area at any given time, because what does the pressure do? It smashes the capillaries, inhibiting blood flow, stopping that wound from healing, and possibly encouraging it to get bigger with the increased dead tissue. So no pressure of that area at any given time. You're going to change the dressing, because remember, this is not about infection. We're not worried about infection. Y'all are worried about, to decrease the risk of infection. For whatever reason, and I still don't know, but decubes on average just tend to not get infected. They look a little angry, they get a little icky, but do they really turn into like sepsis and death very often? They can. But in my experience, we just don't see that very often. And I mean, I've seen some rough decubes, and they just tend to not do that too often. But it's not to say we're not worried about a risk of infection, but that's a different care plan. So just saying, on this care plan, we're going to avoid pressure on that area 24/7, no matter what it takes. We may donut that when they're sitting in the chair to avoid pressure at all times. You're going to change the dressing, and you write that out. Change dressing using 4x4 Aleve per MD order daily, or twice a day, BID, however it's ordered. You're going to encourage an increase in protein. If you want them to heal, give them things that help build tissue. If they're on folic acid, add that in there. If they're on vitamin C, zinc, anything that is about tissue, immunity, and building and healing back. Remember what those folic acids and zinc and vitamin C do. Read what all of these vitamins and minerals do, and then not only will you start them pretty soon, but then you'll recognize how important it is that these patients take that. And if they're not ordered, go to the NP, go to the doctor and say, hey, I was just wondering, I didn't know if you noticed this patient's not on folic acid, right? What does folic acid do? Think of how vital it is for pregnant women who are building a human. You think it's not just as important as this elderly lady is trying to build new tissue into this hole in her butt? So think of those things. And if you don't already have them ordered, don't be afraid to ask. And there may be a reason why they're not on them, and that's fine, but at least you can ask and be proactive and see if you can't help this patient heal. So you can administer all of those, increase protein intake, increase water, increase stimulation, massage around the area, encourage the patient to massage around the area, anything you can do to increase circulation to that site. All of those things will help heal this wound. And then each evaluation is going to be measure the wound, measure the wound, measure the wound. Is it getting smaller or not? And then you can determine whether it's going to, improve. And it's not to say that you're going to do that, every day or at the end of every day. You're not going to see probably a difference in that size of the wound in one day's care, but you schedule it for every 3 or 4 days, and then you should see a difference in the size of the wound. And if not, well, then what you're doing isn't working. Do something else, right? Pretty simple. Okay, so that's in a nutshell care plans. I know it's very condensed, and for the 6 of you watching this, hopefully it'll be helpful. If not, ask, leave some comments, whatever you want to do. I'll be glad to help. So my pet peeve for today is, and I don't know if I've done this before, and I may do it again because every day I hear it. Did I already do it? I may have already done it. Yeah, I already did that one because that's how much I hate it. Oh, here's a good one. Stop ending your sentence with a preposition. And I want to say Verizon used that as a slogan a while back, and I just thought we must have dropped the bar so below Honey Boo Boo that it's never going to raise again, to where they literally had a entire slogan for a multi-million-dollar company that said, "Where you at?" where am I at? I'm hiding behind the preposition in which you ended your sentence, you illiterate hillbilly. Can we just not do that? There's never reason to end a sentence with a preposition, ever. Just don't do it. I try to avoid ending sentences with linking verbs. It's just one of those things. Just do your best. And if ever you ask me, and I know some of you students have, you've come up and you say like, where's the linen room at? First of all, I have to say is, where's the linen room? You don't even have to end it with at, because what am I going to say? It is hiding behind the preposition in which you ended your sentence. That's how I roll. I'm gonna help you out grammar-wise, one way or another, one student at a time, one patient at a time, one coworker at a time. I'm never going to give up. Just never end a sentence with preposition. There's never a reason to do that. Just reform your sentence. There's always a way to fix it. Ask Winston Churchill. Okay, hugs and kisses. See you next time.